friends, it's an immense pleasure to be once again moderating a session to none other than one of my best friends, Dr. Vivek Kumar, not Dr. Viveka. He is also my friend. And they have worked together. So I'm reminded of the time when our President Gary Jail Singh went to USA for his coronary artery problem. I think it was Texas. Dr. Vivek must be remembering. So that was the status some 35 years back. And now we have moved to the stage that we can get a coronary angiography, angioplasty, I think at a village level. So drastic changes we have seen in cardiology and in science everywhere. So firstly I will introduce my friend Dr. Vivek Kumar, who is one of the 10 top electrophysiologists come interventionists. So there are cardiologists who are specialized in electrophysiology. They may not be doing interventions. And those who do interventions, they may not be doing valves. So he is one of the top 3 to name, Dr. Valvular, Dr. Viveka and himself. Those who are doing all the 3, coronary angioplasties and coronary interventions, plus valve and electrophysiology. Yeah, so electrophysiology comes, it encompasses everything. So he is one of the budding legends, alumni of BHU, trained in advanced cardiology at Cleveland Clinic and for TAVI training at Mount Sinai in New York, USA. A vast experience, some 9 to 10 years at Max Sake, and now for 3 years at Apollo Hospital, Sarita Vihar. So he is one of my very, very close friend, and we have seen him, we have heard him in our own group, not once, more than once. At least once he was individual and he has been assisting and aiding Dr. Vivek Kumar. So I must mention that he is known for discovering a rare congenital venous anomaly, coronary veno-cardinal vein. Big cheers for him. So this was regarding his introduction. I think I might have taken a few more minutes. I will just introduce his field and topic today. मैं हिंदी में भी आ रहा हूँ तो मुझे माफ करना। हमने देखा था आज से काफी टाइम पहले कि जब कभी पंक्चर हो जाता था, टायर पंक्चर हो जाता था हमारी स्कूटर का, कार का, तो भैया पहिया खोलते थे, टायर की ट्यूब निकालते थे, फिर पंक्चर लगाते थे। और आजकल एक तो ट्यूबलेस टायर्स हैं, कुछ नहीं करते, सिर्फ एक सुआ अंदर डालते हैं और पंक्चर लग जाता है। To the extent we did it our own self, I did it on my own self when we were traveling in mountains. So they are doing the same thing. They don't open the heart, they don't do anything. Just do the puncture. वो लगा दिया यार, चाहे वो स्टेनोसिस था, रिगर्जिटेशन था, ठीक कर दिया। तो ऐसा करने के लिए एक training, special knowledge is required, and which my friend has. So I'll give the floor to him to explain what he does with the valvular problems. Other than the medical problem which we all do, we also do some medical treatment for the valvular problems when they are not so grave, but they are beyond a level, then you are asked for to give the help. Sir, please come, give us the on-the-spot puncture treatment. Thank you so much.
First of all, good evening to everybody, and thank you so much for such a warm welcome and very kind words for me. So, I don't know whether I can become a legend or not, but I can assure you I am a good cardiologist, and I will prove myself through these examples that I do good jobs.
Very good.
So, as Sir rightly gave, Dr. Kalra rightly gave the thoroughly punctured ठीक करना बिना tired को. I mean, that was great, and this is what we do, and we do this because of one reason. So, why the reason is the temporal changes in demography, Indian perspective. So, we are not now a country of young people. We are a country of aging people. If you see the data, today about 153 million people are 60 years or more. By 2050, there will be more than 347 million people, more than double people who are 60 years or plus. So, what will it bring? It will bring challenges for all of us. As the socio-economic status is improving, rheumatic bowel disease are getting lesser, and it's being replaced by age-related valvular disease. So, with the aging population, what we are going to face is patients having valvular heart disease, having comorbidities like CAD, CKD, liver failure, CVA, and cancer. So, you cannot take out the tire all the time because the car will be so vulnerable that it can just collapse and never run. So this is the problem we are facing now, and we will face more and more tomorrow. So coming to valvular disease here. So we were talking about management of valvular disease in 2024. So these are the valves. You see the anatomy. This is the mitral valve. This is the aortic valve. This is the pulmonary valve, and this is the tricuspid valve. The access to the right side valve is easier. We go just through the veins. It's safe. But challenge is the anatomy of these valves. You see how they are oriented. So the tricuspid valve and the pulmonary valve are just side by side, and the same is in the mitral position. So if you intervene on one valve, the other valve is going to have some issues, and this is what we do. We plan our cases and we plan the patients based on these considerations. So what is the unmet need? So we are going to face people with severe valvular disease of aortic valve, which can manifest as aortic stenosis or aortic regurgitation. We can face patients with mitral valve having mitral stenosis and mitral regurgitation. Pulmonary valve can have a pulmonary stenosis or pulmonary regurgitation, and same is with tricuspid valve. So either the valve will steno, that is, they are not opening well, or they are opening wide apart. So how can we help? So let me give you this case. So this gentleman, 68-year-old male, having angina class 4, dyspnea class 3, and syncope for 1 month. And this is the echocardiogram. You can see this is the position of the aortic valve. You see this white bright spot, this is calcium. And you can see the valve is hardly opening up. It's the another view here. So this patient basically had a bicuspid aortic valve, which we are realizing that it's more common in the South Asian patients. And if you talk about the diagnosis, so obviously it's a severe aortic stenosis. What are the challenges? The challenges are the patient is having rheumatoid arthritis and has a very good history of steroid intake. And he is so frail that he can just walk with a stick. He cannot stand long, and he needs a stick to walk. What, as a cardiologist, should I advise? I would like to seek your opinion. What should I advise this patient? So, Dr. Kalra, please, if you can give me a word, what should I advise this patient?
Dr. Tulsi बैठे हैं इनके होते हुए तो हम कुछ बोल नहीं सकते.
Sir, please. I would like to be. I want this session to be very interactive. I just want to share your experience, learn from your experience, sir. So I tell you, I'll give you something. This is the natural history of aortic stenosis. The history is that you see this plateau This is the phase where the patient is asymptomatic. The day the patient develops symptoms, it's a rapid downhill course. You see the average survival. If the patient presents with angina, he has a 5-year survival. If the patient presents with syncope, he has a 3-year survival. And if the patient presents with failure, he has a survival which can be less than 2 years. More malignant than a cancer you can think of. So, the treatment, the valve needs replacement. But I tell you, a patient with rheumatoid arthritis not able to walk, how you going to change this valve? If you take this patient to surgery, open heart surgery, you open up the valve, maybe you will be able to cut off the calcium and manage to put in the valve. The patient may never come out of the regulator. He may be having an interstitial lung disease, he can get compromised with infection, there could be issues. So believe me, it's a recent case just 2 months back. Patient was sent for intervention to me. I saw the patient and said, dear man, you cannot tolerate a surgery. So, as puncture ठीक करने वाला क्या कर सकता है? We do the puncture ठीक करना. Okay? So what? And this has been, I tell you, a reality. The time I was doing my MD, or the time I was doing my DM, I have seen old patients dying in the CCU where we were just like helpless. Because why? The surgeon will not touch. If you do a BAV, that is valvuloplasty, we used to do it as a salvage when the patient is crashing. 50% of the time the patient will not make a few days. And this, the data says that more than 50% of aortic stenosis patients, they were never operated because of these variable reasons. So, what the guidelines today say? I think this, so let me take you to the flow chart. It's very easy. So we are just not dealing with valvular heart disease. I want to have a discussion that how you are going to approach. So today the approach has really changed. If somebody is having aortic stenosis, patient is less than 50 years, he should go for a mechanical aortic valve replacement. If the patient is 50 to 65 years, an option should be given for a bioprosthetic valve. You remember, we used to say that young patient, mechanical valve. Young patient needs to be 60 years or 55 years less. Today the guidelines have been changed and they recommend that if the patient is less than 50, mechanical valve is the answer. 50 to 65, you can give an option of bioprosthetic valve or mechanical valve. If the patient can afford a bioprosthetic valve, he should go for a bioprosthetic valve. The reason is quite clear. You must be knowing the difficulty in managing INRs. A lot of time you will be receiving patient, मेरा INR अभी 10 है मैं क्या करूँ, मेरा INR 1 है क्या करूँ. You cannot rely on the lab reports. You are just trapped. So that is the reason why, and today there is an option. The reason we propose mechanical valve in younger patients because bioprosthetic valves, they fail, whatever type of valve is, it fails in 10 years average. So if you put at 50, the patient will need a re-intervention at 60. Earlier, you never had an option to a redo. Nobody dares to do a redo open heart surgery. But puncture ठीक करने वाला कर सकता है. So क्योंकि puncture ठीक करने वाले आ गए हैं, so we have guidelines being modified. They say that if the patient is less than 65 years, surgery is the option. If the patient is more than 65 years, puncture ठीक हो सकता है, and it can last. So, TAVI, that is transcatheter valve implantation and surgical valve replacement, they are both the option in patient who is more than 65 years up to 80 years. But if somebody, for India it will be 70 years. If somebody is more than 70 years, no doubt that TAVI is the choice of therapy. But there is a catch. Even if the patient is 30 years old, even if the patient is 40 years old, even if the patient is 50 years old, and the patient is too sick to get an open heart surgery, TAVI remains a viable option. So, let me show you what I did in this case. So, I tell you this has been one of my challenging cases and the most difficult to do. So, what we do, we like a puncture, we take in a puncture in the femoral artery. This is the calcified valve, we cross through, we put in a wire. Initially we put in a soft wire, we change it with a harder wire so that we can pass something. And this you see that valve is not opening. We did it 2 times dilation to make some space for the valve to be deployed. You can see this 10 here, this is the calcium. If I inflate more, the valve will rupture, patient will die on table. But believe me, we plan this procedure before we actually do a puncture. We have a plan A, B, C, D, E, Z ready. We have all the hardware ready to manage all the eventualities. And this is how we are deploying this valve. And this is the place it should be deployed, just almost 2-3 millimeters below the annulus, so that you have enough tissue to catch it, because we don't suture it. We use physics here. Newton's third law. More you push, so to every action there is a reaction. So we put an oversized valve. The tension that it creates outward holds the valve here, and the calcium is a friend here. But at times it can be nemesis. So the valve is done. The procedure was done in 1 hour. It doesn't require general anesthesia. Patient is ready to walk after 6 hours. And I will show you the hemodynamics. So you can see here, this is the pre-valve intervention hemodynamics. You see the aerobic pressure is 116. The LV, the heart is generating a pressure of about 198. So there is about 82 millimeter gradient. And you see after valve implantation, 0 gradient. So valve is done, and this is the patient. 1 month after, you can see such a frail patient with a stick, and he is 1 month after the surgery. And believe me, I don't know whether he would have survived the surgery or not. Second patient, 67 years, NYK class, 3-4 symptoms, syncope, severe AS, but this patient has no other comorbidities. What should I advise this patient? So as I said that in 65 years above, you can give an option of Davi. The reason is, I'll show you the reason. 24 hours post-procedure, patient is in the room ready for discharge. So this is the reason you can give to patients who want less hospitalization, they want to come back to their normal life, and this is why you do Davi. And you can see in this patient, so the same thing was done here, and you can see here the gradients, almost equalization of the gradients here. And patient 24 hours back, and she is doing great. So, okay, this was another patient. So all the time you must have heard that surgeons, the cardiac surgeons and cardiologists fighting. This is one place we become friends. So this lady, you can see she had also a rheumatoid arthritis. You can see how frail she is. And this was referred to us by a cardiac surgeon. The cardiac surgeon told, dear Vivek, I cannot do a surgery because she is having a porcelain aorta. I don't know what will happen if I put a valve. And she is 1 month post-Davi, doing great. It's been 1.5 years now. So it was one of my initial cases at Apollo. So this is the story. Now I am giving you another case. 56-year-old, severe AS for echocardiography, no comorbidities. What should I advise? I advise this patient, this was an international patient, he came to me for Davi. I said, dear friend, I can do Davi when you grow up 66 years, now get a bioprophetic aortic valve implantation. He get it done, he went back to Boston, he is doing fine. Without any anticoagulation, he is doing great. So this is, if you see the scenario, let me sum up with how you are going to manage aortic stenosis today. Aortic stenosis, age more than 65 years, Davi or TAVR is a good option. But high or cognitive risk, that is the patient is sick for surgery, irrespective of age, Davi is the option. If there is aortic aneurysm, currently open heart surgery, Bental is the choice, but believe me, we are working on a new system, a advanced catheter system where we will be replacing the aortic root as well as the valve, and so it will come sooner than later. In AR patient, today we are having dedicated valves being experimented, but as of now, Davi or TAVR can be done only in a high-risk patient, but rest all should be managed with SAVI. But all the bioprosthetic AVR failure patient. So somebody who has a bioprosthetic valve at the age of 60 years, he comes with a redo surgery. He will never do a redo surgery. What he will do? He will do this. So this was a bioprosthetic valve implanted, and we are deploying here a balloon expandable mitral TAVI valve in there, and this gentleman required an angioplasty to the left main also. So we can do an angioplasty and a valve implantation at the same sitting. So it's not that if there is a aortic stenosis with a CAD, the patient needs CABG with AVR. We can do a angioplasty and a valve implantation either in the same sitting or we can stage that. So this patient had a bioprosthetic aortic valve failure and he successfully underwent a TAVI valve implantation. Now, a case of degenerative mitral valve. So after aortic valve, let me briefly take you to mitral valve. So this was a lady, high, very frail lady, 65 years old, having atrial fibrillation. She had a surgical MVR done in 2017 and this case was done in 2022. In 5 years, the bioprosthetic valve failed. So what should we do in this patient? She had a risk of about 5% of mortality on table and overall 25% chances of having severe morbidity and mortality. So if you tell somebody that there is a 1 in 4 chance that you will be either lying in the hospital for a long time or dying, guess what? Will the patient choose? They will never choose that. But what we did this. So we went through the right side, the femoral vein, we punctured the interatrial septum, entered the left atrium. This is the bioprosthetic mitral valve. We made a space in the interatrial septum and we now crossed into the mitral valve. Here, this is the mitral valve. This is the surgeon's implanted mitral valve. We dilated it and this is the valve we are taking into it. So we are just using the surgeon's valve, we are going to implant a mitral valve there so that this valve starts functioning. And this patient is now more than 1 year. She is doing great. This is a very tricky thing. You have very 1 few millimeters of margin. Either way, down above, your valve will just pop off, and then you can't do anything. So, but we have to be meticulous. This is the risk that we take, and it comes by experience. And you can see that this valve popping, but we again pull it back so that we have a good hold there. And gradually, so at this time, the flow in the heart, blood will be 0. No blood at all flowing. But you deploy it, the heart is almost standstill. But we just pray to God that it starts beating again. And you can see it started beating. And the procedure is done. I'll show you this is the pre-surgery echo. You can see the sac here. And after that surgery, I'll show you the image. This is the valve opening valve. So, it's done. Now this gentleman, a 94-year-old young male, a retired IS officer, active and alert, and believe me, a big Modi supporter. I'm not very but you know, when you are doing patient thing, you just forget about your own. So he is a patient having hypertension, COPD. He was doing well. Suddenly, for 7 years, he presented with severe shortness of breath. He went to the physician. He was treated for acute exacerbation of COPD. Came to me in the emergency. I saw the picture, auscultated. It was very clear that the patient is having CHF. And on auscultation, there was a pan-systolic murmur at apex. So if you have a pan-systolic murmur at apex, you just think one thing. The valve is leaking. And which valve is going to be? It's going to be the mitral valve. And it was. I'll show you the echo. You see here, so this is the transesophageal echo. This is what we call PML, that is the posterior mitral leaflet. So both leaflets should align at one level. What you can see here is that the PML is bouncing back into the left ventricle. Why it's happening? Because there is this anchor, you can see here, the right anchor of the AML is there, but the anchor of the element PML is lost. So with A, the PML ruptured, the anchor ruptured, and the valve becomes blocked. And this patient, this is the resuscitation. What can you do in this patient? 94-year-old, open heart surgery, you will never think of it. But what you can think of it is doing this procedure we call it a mitral clip. We can put a closed clip-like thing, and we can use the other valve as an anchor to hold the valve. And this patient is in waiting actually. We are going to plan it soon. Okay? So this is another case done. You can see in this patient we have to put 3 clips to hold the valve. So regurgitation you can treat with this. So what is the current scenario? Okay. So biprosthetic valve failure, mitral ring failure, TMVR, that is transcatheter mitral valve replacement, that is the puncture technique, works well. But yes, if not a good candidate for redo surgical aneurysm. For mitral stenosis, our good old DMV still works and we are doing it. We do that very frequently. For mitral regurgitation patient, it is a primary MR. Primary MR means the pathology is in the mitral valve. In that scenario, we have options of mitral valve repair, replacement by robotic, open or MICS. If the patient is high risk, we can do a mitral clip. We can just clip that valve and the regurgitation can go away. If the patient is secondary MR, this is challenging. So, you have a patient whose EF is 30%, patient is NYHA class 3, you have exhausted everything. You have put in CRTD, you have got medicines like the 5 pillars or 4 pillars, whatever you want to say, but still the patient is symptomatic. What are you going to do? And what you see in the echo is that patient is having moderate to severe MR. You can go in, clip the valve, and believe me, it works. The patient can become reasonably asymptomatic, and you can add something to that. Now coming to tricuspid valve, as I was saying that TRIC valve is an option, but yes, this option is for low pressure TR. A lot of time you will see that your patient is having leads in the right heart. We think that the right valves are inoperable. Today I had a patient who was having severe TR, congestive hepatopathy. That is the only problem this patient is having. But these patients are very high risk patients. The reason is that the tricuspid valve is difficult. First, the anatomy is difficult. The system is low flow. If you put a mechanical valve, it will compose. So often you use bioprosthetic valve. But a lot of times the patients will not be a good candidate. But yes, in certain group of patients who have low pressure TR, that is the systolic pulmonary artery pressure is less than 65, what you can do is that, what has been seen, that if you can prevent the regurgitation into the SBC and IVC, there is a positive remodeling happening in the RA-RV that may not alleviate the TR, but it will alleviate the symptoms because of congestive hepatopathy. And this is what we do here. What we do here is that, so this was a patient who had a previous ball and socket mitral valve, the AICD leads and everything. What you do here is that we put 2 valves, we call it a bicable valve. So first valve goes at the junction of SBC and RA. Its job is that nothing should go above into the SBC or the CNS. Okay, so you deploy a valve there, and this is the mark. So this is the, what we do is that we put a catheter in the right pulmonary artery, and that is the separation, gives us separation of the junction where SBC meets the RA. So this is where we deploy the valve, right? After deploying the SBC to RA valve, we now deploy the lower valve. So here we make sure that the hepatic vein is not compromised. So this lucid marker should be above the hepatic vein. So we put in a catheter in the hepatic vein, and then slowly we deploy this valve here. You see here we check that the hepatic vein is flowing, and here what we do, we prevent regurgitation from RA into the hepatic veins and IVC. So this way this valve works, and this is what a TRIC valve is. So I tell you it is the most easiest of valve intervention. So what is the current scenario in tricuspid valve? So I told you most difficult valve because of low pressure system and high risk of thrombosis. If there is a biprosthetic valve or ring failure and we have to do a redo valve intervention, transcatheter tricuspid valve replacement is a good option. If there is a low pressure TR, TRIC valve can be put in. In certain cases we can clip this valve here. We call it a tri-clip and it can be done. So today's patient, he's having mitral regurgitation as well as tricuspid regurgitation. What we are going to plan is we are going to predict the severe friends are doing a good job, but I think they are lagging a bit. But transcatheter valve intervention has come as a boon. The transcatheter valve intervention is almost matching up to the unmet need of high-risk patients of valvular heart disease. But it's important to carefully select the most appropriate patient for the most appropriate procedure. That is the key. Future evolutions are going on to tackle other complex matters. All I can say is future is bright, but yes, cost is a major. That's all from my side, and this is a very important thing. Let me just give you the history of this building. I think all the interventional cardiologists owe to this building because this was the building where first angiography was done by Mason Stones in 1962. So we were born there. And I had the privilege to be there and make myself late. Thank you.
Sir, please sit there. Sir, Dr. Kalra, sir, you also be there. You also be there.
मैं जरा बोलेगा
Mic is it, sir? Take minute. Friends, we had a wonderful session by Dr. Vivek. I'm sure you would be having many questions. My request to all of you is to please ask your questions through the moderator. Okay? And let the moderator give his comments first, and then we'll take it from there. Over to you, sir.
Thank you, Dr. Sushil, sir. Friends, we know what a wonderful talk once again from our budding legend, I say. So, my comment opening is that surgeons are becoming more gentle, more minimal invasive. We have one of the surgeons amongst us, Dr. Palvi. Surgeons are becoming less aggressive, and interventional cardiologists are becoming even more aggressive to the extent that they want to do everything. And I think there should be a common minimal program like we have in Mahagarthaman. So I think you have a team when to decide which one will be taking lead. So my understanding says that if one is young and a valve has a problem, it should be metallic replacement, which has been our gold standard till now. Any change below 50, we go for metallic, and even metallics are getting better. And they don't have the same texture as they were having earlier. Even their probability is lesser. Your comment?
Sir, so very rightly said, sir. First of all, that definitely our surgeons are still very aggressive, and I think they are becoming more and more competent. Because earlier they used to do very simple cases. Believe me, used to have CABG for just single graft. But today they get leftovers from us, where we cannot put a stent, we send them to surgery. So they are really becoming more and more competent, I'll tell you. So coming to your question, sir, yeah, definitely the metallic valves are very good, but still you need to give anticoagulation to them. So nowadays, sometimes we accept PTNR, usually we say that it should be more than 2 and less than 3, almost most of the patients. Apart from certain groups where we want that it should be only 3.5, like in patients who are double value replacements. So, but now we accept even if the INR is 1.6, 1.78, 1.8, we accept. Because definitely, as I said, that valves are really becoming better, less prone to conflict, but still you cannot say that the patient will not need a anticoagulation. And that is the most important reason why it's difficult to manage.
I'm leaving my academic questions to my friends, Dr. Chauhan and Dr. Tulsi. A few simple common sense questions like which one of the valves, the 4 valves, is more benign? Is it pulmonic valve? We have never heard any intervention being done there.
So, sorry, I skipped that slide actually. So, usually pulmonary valves mostly don't require any intervention. Even if they are having resignation, the patient tolerates well. If the patient is having pulmonary stenosis, which is mostly congenital, you can just balloon dilate it and you can do repeat dilatation. It's very compatible valve and they don't really bother a lot. And even the balloon dilatation works. Pulmonary valve replacement now comes to picture in patients who are like a congenital heart disease, having got operated at a young age, particularly in patients with clot. So they have like a reconstruction of the pulmonary valve. So there they do is that they become degenerative. And you can simply put a valve there. So there are dedicated valves as well, and you can even put the tubbing valve there. So, but they are less commonly done.
So which one out of aortic and mitral valve, regurgitation or stenosis is more symptomatic? Is it more aortic valve which is causing more problem, like we say SAD, like syncope, angina, and dyspnea?
Okay. So if you say aging population, degenerative aortic valve is the aortic valve which is more. For rheumatic heart disease, it was mitral valve which was more common. But for degenerative heart disease patient, that is older patients, you find aortic valve degeneration more commoner than the mitral valve. Maybe because of the long-standing hypertension and diabetes. Look, so aortic valve has to open from against high pressure. Your systemic pressures may be 160, 150. The mitral valve needs to open with a pressure of about 12, 20 mm, at least not more than that. So very likely that in age, the aortic valve is more going to degenerate, and that is what happens.
Thank you, sir. I will save questions for my friends.
It's a wonderful talk, Dr. Vivek. I understand that you are doing across the spectrum things in cardiology. You are doing structural, you are doing interventions, and you are doing electrophysiology also. Since structure is very close to your heart, I wanted to ask you, when we were doing our MD in 86 to 88, rheumatic heart disease was very common. And we used to have something called a rheumatic clinic in Sutherland Hospital that we used to run. Sir, in your experience, over a period of time, sir, we see that the prevalence and incidence of rheumatic heart disease has become much less. So do you agree with this observation?
Sir, definitely I'll agree. Maybe because of the social strata that we are dealing with, we are having less of that kind of activity. Because you will agree with me that rheumatic fever and rheumatic heart disease is a socio-economic disease. Mostly common in people who are low strata, crowded environment. If you go to backward states like Bihar, Eastern UP, you will still find those patients. But I tell you, there also, the incidence has decreased. Maybe because of use of antibiotics in younger patients. I mean, that could be a reason, because every quack or everything they will give a azithromycin tablet or a rheumatic tablet to any drop fever. So that thing, that way we also contribute. But you're right, that we are seeing less and less patients.
Sir, many times we have double whammy. We have mitral condition and we have aortic condition. Now, if we had a case, let's say, of mitral stenosis with aortic stenosis, which one would you operate first?
So it's very difficult. So if it's a young patient, and the guidelines are very clear on that either of them is severe and the other one is more than moderate, both needs intervention at one time. So the problem happens when the other one is like borderline, both suppose somebody is having severe AMS and severe AS. So for academic discussion, you can say that maybe the evaluation will be difficult, because if somebody is having severe MS, the gradients across the AS will not be so much. So there is a chance that you can have an underestimation of aortic stenosis. So in that condition, you have to really quantify through CAP studies and hemodynamic studies that okay, the aortic stenosis is still difficult. If the aortic stenosis is not more than mild, you don't have to treat it. You just treat the mitral valve. Okay. So usually the proximal valve needs to be treated first, then you go for the
Right, sir. Sir, you mentioned one of the slides you showed very bad progress of aortic stenosis once it becomes symptomatic.
Definitely.
It is actually lessen the prognosis of malignancy.
Definitely. No problem.
Sir, I wanted to ask you in TAVI that you mentioned, there are two the valves that you are using are the prosthetic valves. And these prosthetic valves, at times, they have a tendency to degenerate. Sir, in your experience, and from your wide experience of the trials that have been done, what is the average life of the prosthetic valve that you put in Cmes?
Wonderful. I think that's a very good question. So, just to start with, so there are two types of valve that we are deploying in Cmes. One is the self-expanding valve, the valve which opens like a net, you saw that. The other one is where it inflates, it's like a simple stent. So it's a valve which is mounted on a balloon. You open up the balloon, the valve will get open. So basically there are balloon expandable valves and the self-expanding. Both have different hemodynamics. The data is best for the self-expandable valves because I said that we use Newton's third law. We put oversized valve there. So if you compare the longevity of a surgeon implanted valve and a Davi valve, the Davi valve lasts longer, and it has been proven recently by a lot of data that 10 years longevity is very much better with compared to a surgically implanted valve. So the first Davi happened in 2002. So you just have 22 years of experience, right? The initial Davi patients were patients who were like very sick. So most of them have either died or very less have survived because they were like very sick patients, 90 years, 75 years, having lot of injuries. Nowadays, for the last 10 years, we are putting valve in a lesser sick patient. So if you ask me what can be a likely longevity, it will be on an average 10 years because that is what we are seeing from the surgical valve. The best part is that now whenever we deal a patient and decide about a therapy, we think about lifetime management of valve. Because earlier, the valve would not last beyond patient's age. But today, patient's age lasts beyond the valve. So there will be a scenario where you may have put a valve in a young patient and now the patient is fine. Initially he was 30, now he is 60 and he has no comorbidity. Then he should have to do a redo, maybe you can think of a redo surgery, then Davi. Okay? But there will be scenarios where you think that okay, the patient can have a redo Davi also. So you can have a surgical valve implantation, you can do a Davi, then a re-Davi, or it could be other way. So this is how we plan basically.
Wonderful explained. Sir, some questions are very dear and very close to my heart, and those questions are regarding the anticoagulation. We know that when we do a surgical area, the patient would require anticoagulation for life.
Yeah.
And they'll go to the PTIR every week. Sir, what about diving, about the prosthetic valve? What kind of anticoagulation, what kind of antiplatelet treatment or therapy is being used, and what do you give your patients suppose you put the best valve in Cmes to your patient?
Sir, I think it's the most relevant question, and I think that is the USP of this technique. As I said that this technique is done in high-risk patient. We started in a high-risk patient. Now we are translating it into a lower-risk patient. So obviously, what are our high-risk patients? Our high-risk patients are patients having liver disease, kidney disease, uncontrolled blood pressure, cardiopathy, and these are the patients who bleed more. So obviously, the antiplatelet strategy, we don't give anticoagulation here. Usually, most of our patients, we give dual antiplatelet for 1 month.
Only
dual antiplatelet for just 1 month, and thereafter single antiplatelet.
So aspirin only.
That's it.
That's it.
That's it.
Okay.
So that is the beauty of this technique. So even if your patient has sometimes he has stopped any. So we had a few patients who were not tolerating even aspirin. We stopped it. Patient is doing that.
Nothing happens.
Usually it's recommended, but if you have to stop it, you can stop.
Right.
That's it. The valve will not promote.
Sir, you also mentioned briefly about valve in valve.
Yeah.
Now suppose the prosthetic valve degenerates. Can you put another valve into this valve?
Very easy, sir. And that is the more easier procedure to be done. Because you have a platform there, a metallic platform there to put in a valve. So it's it's very busy. So you saw when I was showing a case in a native aortic valve, you have to inject a dye to see the plane of annulus. But if a surgeon has put a valve there, he has an annulus there. You can see it. So you can precisely put your valve, and we don't cut open the leaflets. We just put in another valve inside it. So those leaflets at times can create problem for us because they can close up the native coronary artery. So we have techniques for that. We manage. As I said, that when we are doing a TAVI, we have a plan A to Z ready. That's what actually is totally based on safety. So we analyze safety. I should have shared that slide also. So we have all the parameters. What are the peripheral blood vessel diameters? What are the height of coronary vessels? What is the size of the annulus? What is the size of the aorta? Which size access is better? So sometimes the femoral artery is the default approach, but sometimes somebody can be having a aortic interruption. What can you do then? So there are options that you can go from the axillary artery or the subclavian artery or the carotid artery or even direct aorta. So these are all options. It's totally planned on a CD. We need a good CD and we plan it and treat it.
Sir, you mentioned about the trick valve, and I understand that you are one of the few persons who are actually adept at doing the trick valve. Sir, what is the cost of doing a trick valve in your setup?
It's the most costly.
Would you just
It should be around 25 lakh rupees. So there are two valves, so that's why it's costly.
I'm coming. Sir, one last question, and I hope you will forgive me for this.
No, sir. My pleasure.
Do you ever call Dr. Vivek in the midst of a case? Sir, I need your guidance.
So I tell you something. So, sir knows this. So when I came to Apollo, Dr. Vivek had gifted me. So what happened that there was this new leg aprons coming up. So Dr. Vivek had his apron. So I said, sir, can I have this apron? It is 2018. So his leg apron is still with me. So whenever I do the procedure, he's somewhere there. So that's the thing. I really respect him. I've learned a lot from him, and he's always in my thoughts here.
Thank you, Dr. Vivek. We love you for this. Dr. Kodam sir.
So when you are doing TAVI procedure on a calcified aortic valve, so when the valve is calcified heavily, then is it a difficult situation?
Sir, yes and no. The reason I'm just deviating to get a premise why I said this. So the problem with aortic, I said that in aortic regurgitation, TAVI is not the first choice. The reason is in aortic regurgitation patient there is very minimal calcification. So as I said that you Newton's third law, we need something to have a friction. If there is no friction, our valve will just pop off. So, having calcification, but calcification at good places is really helpful. But recently I had to try to cancel a case, so you won't believe, I mean, it was so shattering. This lady, about 75 years old, 20% ejection fraction, having severe AS, but her calcification was like this, extended up to the alveoli, and there was no space where it can open up. You cannot rupture that thing because the patient will die. So calcification is good, but we want it at a very good place. Like we want it to be uniform. We don't want chunks of calcium. We don't want a bicuspid aortic valve where there are like boulders. We don't want that. But yes, sometimes we have to face it. As I showed that case, that was a very challenging case. A few mmHg more of pressure would have ruptured the annulus and patient would have died. So this is what comes with experience. So calcium is good and bad both, sir, I'm saying.
So when you fix the valve there, then how do you decide that this is at the right position? And if you think it is not at the right position, can you refix it in different position?
No. So ये फिर वो शब्द भेदी बांध जैसा है, एक बार चल गया तो वो बंद करके ही आएगा. तो इसीलिए जब भी हम डिप्लॉय करते हैं, so this Macron's valve, it has a very good deployment technique that we can almost deploy the valve at about 80%. So till 80% you can check whether you are properly deployed or not. If you are sure you can release the valve. If not, you can recapture it and redeploy it. But this cannot be done with a balloon expandable valve. There you just have to deploy it for it.
For mitral clip, it can be done.
Yeah.
For mitral clip.
It's more technically challenging, but it is very good.
I would request Dr. S.K. Mathur sir, better on the forum to ask a question.
Sorry, this is not a question, I am sharing a case. And I want opinion for everybody, and particularly you and Dr. Kalra. This is a very close relation of mine. She went to travel in the eastern sector at Guwahati and Shillong. Came back, was fine. Before that, she was absolutely fine. She had mild hyperthyroidism, mild hypertension, no other comorbidity. Sudden development of restlessness, acute restlessness. No fever, no cough, no other thing. Hospitalized, did an X-ray found a pneumonic patch on both the lungs and suspected antiviral pneumonia as the only. Treated by antibiotic in ICU and therapy, she did recover. But nonetheless, she was slightly better than before. We were discharged. Bronchoscopy done, echocardiogram done, nothing they found. Could be heart rate was normal. I'm coming to that. Echo was absolutely normal. That one suspect could be other cardiac failure. Anyway, so absolutely normal. She continued treatment for about 2 weeks, no improvement. Then she went to Dr. Mangla, who is there right now. Who first thought about there could be something else. He did all the tests and found out in echocardiography there is an acute bacterial endocarditis.
You said it was normal.
First echo was normal. 2 weeks later,
Discovered that
2 weeks and that was the point where the suspect sepsis. It is now with Dr. Vivek Kumar and Vivek Saki. She, of course, being given IV antibiotics 3 times a day. Now my questions are what I want to ask about, since you want to very closely. What is our prognosis? How long antibiotics to be given? And what is the future for such patient? And she has mitral leak down in the echocardiogram.
So it's a very difficult case to treat if it is a elderly female patient.
74 years.
Yeah, so very elderly. So I tell you sir, one thing I know about echocardiography. The saying that I see what the mind knows, I mean that applies to everything. It's not that the vegetation would not have been there in the first place.
Probably
Not only that, even the signs, the 5 signs of endocarditis should be there.
the echocardiogram is done. That was so
Echo proved that. What about the signs? There are 5 signs of endocarditis.
Sir, it's
But it
not
was written by cardiologist there.
there. I tell you, वो जितने भी signs है बहुत rarely.
There was no fever. There was no fever for the
Sir, so इसको भी call it as subacute bacterial endocarditis.
It's probably acute. I would say that is acute.
So I think usually it takes about 2 weeks to 6 weeks of treatment, depending upon which bacteria it has grown. So there are certain bacteria which need 2 months, 2 weeks of treatment, certain bacteria need 6 weeks of treatment. But unfortunately, it's mostly injectable. So that's the problem.
So now, we continue antibiotic for how long? Depending on
Yeah, I think it's
the But the only complaint she has now, sir, tremendous weakness and a poor appetite.
So maybe the vegetation is playing some part there. The mitral valve.
I would request Dr. Vipul, our anti-medicine diploma in cardiology from UK also, to ask at least a few questions to Dr. Vivek.
5 signs.
Dr. Vipul Mohan is the son of legendary cardiologist Dr. Jeshimon. Ask a few questions.
Good evening, sir.
I think you were in maths.
No, that was my love.
Oh, okay, sorry.
So I just wanted your take on how mitral patients do, let's say, a year later. Because so I happen to be non-invasive, so I see a lot of post mitral clip, and unfortunately we see a lot of requirement for T2. So I wanted your take on it, like how do you perceive the 1 year or a 2 year status?
So what we call is that SLR. As I said that whenever you do a mitral clip, you use the other leaflet for a hold.
Manish,
So if the catch is not proper, the leaf, the clip
Manish,
is not
can you just be
there
here
is a rare chance that it can just come off.
I just request all of you please be flexible for next 10
So it's
minutes.
very important that which patient you are offering it. So it's not be offered to any patient who comes with mitral deformation. It's going to be offered in patients who you think that the surgery is not going to be an option. So in that case, it's worth taking attempt there. Or if you see the patient is high risk for any other procedure. So definitely deployment is very important.
But are we actually, like you mentioned, patient choice and everything, patient selection basically, but are we developing a criteria for the Indian subset for doing the same?
No, the criteria is very clear. Okay, there is a definite thickness of leaflet that should be present. There should be a definite length of leaflet that should be present. So I don't know the operators who are practicing it are following it to what extent, but the criteria are very. So what you can IFQ indicated uses low the leaflets are. So there are very well made criteria and you can expect a decent result 2-3 years because look, we are talking about patient which is very sick. I don't know whether they are going to last that procedure or not. They can have other issues and they can set down. So what we are trying to do is that we are trying to add life years to a patient who is losing life. So here immediate outcome is more important than long-term outcome. But yes, you can do redo procedures that are really an option.
So mitral redo, what is the success rate?
It is doable, but it all depends when the patient is being diagnosed. If it is delayed and already patient is having a in-stage heart failure features, we can't do much about it. So the index procedure is very important. It should be well planned and executed.
I would like to ask Vipul, she does a very good job on echo. Which is the most difficult valvular condition to diagnose and quantify?
I think sir would agree, valvular PS or something like let's say, now today I had a case, we had a LM myxoma and the AML was completely orientated. This is the case where you're stuck. What do you do about the mitral valve? And but even with surgery, now this myxoma, the length, you can imagine the entire AML is orientated. Throughout the length of IAS, it's stuck. So the length was around 7.9 centimeters or something. These are the cases where you get stuck. What do you do about the valve and then what do you do about the...
So I think the surgeons can do a good job there because usually myxomas have a pedicle. So you size the pedicle, your valve will release. But it all depends that there is a relative.
But AML was completely operated.
Obviously the patient may need a valve replacement at the same time. They can do it. So I'll give my take, sir, about your question regarding which valve is very difficult to assess. For me, I think it will be aortic valve. The reason I tell you, in 11 people, what I've seen is that you are not able to align your probe properly. So you have to be anterior. A lot of time you will be under measuring the gradient. A lot of time I have seen patients. So I very rely on my stethoscope. I tell you, still it's useful, and I have myself picked up at least a few cases where echo has been done, mild AS is mentioned, and you also take there, you see that the A2 is soft, you see that the murmur is related to carotid, it cannot be mild AS. And that patient came on to be serious, and we did a TAVI in that patient. So I think aortic loss is the most difficult one, and other is, I'll say, hypertrophic cardiomyopathy. I mean, a lot of times you say there is a turbulence. Try some Valvular maneuver. If it is increased, that means this is the obstructive cardiomyopathy. It's not simple hypertrophy. Sir, day before yesterday I did alcohol septal ablation plus angioplasty. I don't think anybody has done it before. I'm going to publish it. I checked that. So this gentleman was sent to me for area, right? TAVI actually. I saw that patient and it was like atypical ejection systolic murmur. You won't believe, in echo, the baseline gradient was 104. On Valsalva it was 146. So we did an alcohol septal ablation just day before yesterday. The patient is discharged today. And the gradient came on table it was 6. But obviously you have edema and things like that. After it's 70. So it's I want to show that in this case also, but I thought maybe someday else. But that was a very good one.
My message is, if you want to get your cases diagnosed, send them to Vivek. If you want to get them treated and cured, send them to Dr. Vivek. All right. Thank you, Dr. Vipul, for your report. Dr. Luthria, sir.
We would be having a large fair number would have it. Do you still recommend only 1 or 2 months of anticoagulant, or you give anticoagulant because there is anticoagulation?
Sir, I was talking about post-TAVI intervention. For aortic valve, it is 1 month of dual anticoagulant and thereon single anticoagulant. For mitral valve, it doesn't apply. Or if you are doing a mitral valve, there we like to give dual anticoagulant for a longer duration. Or if the patient is having AF or any other thing, then NOACs is the default anticoagulant. Whether the patient is anti-valve.
Anybody has a question here? Anyone has a question here? All right. I will come to the master, Dr. Tulsi sir. Sir,
I'm waiting for his patient back.
get ready for your DMI.
Thank you, Dr. Kumar. No DM Viva. Very simple questions. So, Dr. Vivek, it's an excellent talk which you gave. Also presented some wonderful cases. I would have loved to interpret those cases as well. But anyway, so the current evidence is, due to multiple large-scale trials, favor and support transcatheter treatment for valvular diseases. It's the frontline therapy for treating aortic stenosis, whether it's mild, moderate, or severe. And can you tell us how do you define low risk? Is it the age, is it the score, is it the comorbidity? Probably in totality. How do you diagnose or how do you define low risk? Can you tell us that?
Sir, it's a beautiful question. So, when we were doing this procedure to start, I hope I'm audible.
Can we have some decorum at the back, please, again?
Hello. Yeah. So, when we were doing this procedure initially, we used to classify patients based on low, moderate, and high risk. The criteria was what we call STS score and Neuro score. So they are like online apps available. So our European and American friends have made this criteria based on patients' ejection fraction, diabetes, hypertension, history of addiction, alcohol.
So those are comorbidities. What about else? Like age
is also
score,
so
probably totality.
So there are multiple 10, 12
including comorbidities.
Yes. Previous heart surgeries, previous angioplasties,
Absolutely.
everything is there. So it's an extensive scoring system, but today we don't use it.
You don't
so as
use
I said that 65 years is the cutoff. Above that, you give the option, you explain the pros and cons. If the patient is ready, you go ahead for TAVI. If not, if the patient goes for surgical valve replacement. If the patient is more than 75, 80 years, TAVI becomes the default option.
So age is very important.
Age is very important.
Okay, let's proceed further and talk about Dr. Chauhan talked a little about the redo procedures involved. See, so what is the recent ACC guidelines? The recent update said that probably, there is no additional risk in doing the redo valves. What do you say?
So it all depends upon the center and the experience of the center.
Experience of the,
I tell you, I haven't met a surgeon who is very comfortable doing the redo. So a lot of times they send the patient and I've seen patients succumbing to post-operative comorbidity. Actually, I am. So a lot of time it's been that I am not leaving. So I have seen sometimes that so I have seen some patients getting complications. So it all depends on the center and the experience.
So, Dr. Vivek, talk us about what? A balloon, expandable or self-expanding balloons. So, what's the difference and what do you prefer? Do you prefer balloon or expandable because of the precise positioning and the deployment and less complication as compared to the self-expanding which had increased pacemaker implantation seat? Talk us about the two, the balloon expandable and the self-expanding.
So, as I said, that whenever we decide upon a valve, hello, yeah. So, I was just saying that when you decide about a valve, we talk about a patient's lifetime management. Okay. So, if it is a younger patient, in that scenario, a balloon expandable valve could be a better option because you can put a redo, when you are doing a redo TAVI, putting a valve in a balloon smaller stent, so balloon expandable has a smaller height compared to the balloon self-expandable one. So if the younger patient, that is the default valve in most of the cases. But if there is a lot of calcification, there are issues of when you want to be a very precise deployment. There is an issue of large annulus and you think that it can migrate. In that situation, the self-expandable valve gives more control because I said that you can recheck just before the release of the valve. So that makes this valve very beautiful and unique. So we have to decide upon individual conditions and individual challenges and both valves are good, but in certain scenarios one is preferred over the other.
Let me dwell upon a case which I discussed with Dr. Kalra only yesterday evening, and he would remember it. A 61-year-old man had STEMI, PCI, delayed PCI was done to the LED, presented with NYHA class 3 after 3 months. Had an injection fraction of 20 to 25%, had CKD, had also ischemic cardiomyopathy, echo showed severe MR with TR. Very important, echo showed severe MR, severe TR. BNP more than 5,000. Angio, no stenosis. No stenotic lesion. So what would you prefer here? Would you say heart transplant, LVAD? Remember, this is a severely symptomatic patient. So surgical options, GDMT, heart transplants, LVAD or percutaneous catheter intervention. What would you prefer here?
Dr. Tulsi, what is the age of patient? That is important. What is the age of patient?
I said 61.
61.
Come here.
You are telling your own age or the patient's age?
Come here. Sir. I'm just 45. Come here. So,
Sir,
talk about this.
Yeah, but
Rakesh, come.
I
We'd like
think,
to discuss with you. Come.
So this is a very real world patient. I tell you, you said that it was your patient, and we often.
Not my patient.
Okay.
But I studied for this patient.
Okay.
It was published it was presented in the ACC conference in April and presented in NAGM.
Oh, wonderful. So, sir, I have some leading questions. So, what was the ECG?
ECG.
Was it a narrow QRS or wide QRS?
No, it was normal. Normal QRS. And less than 130.
Okay. And it was post MI 3 months.
Post MI 3 months, delayed PCI done to the LED.
And no stenotic vessels.
What I said, angiogram was absolutely pristine.
So this patient should be given an option of a mitral because this patient is going to benefit all of us.
So, no transplant, no LAVD, no GDM. He was already on
expected to be on GDMT.
So, he said, Dr. Vivek said, mitral clip and what about tracklip?
Yeah, both of them.
Wonderful, sir. This was an eye-opening case. Great, sir. Wonderful. Thank you so much. Talking now, my last question to you will be regarding atrial fibrillation, which is a common comorbidity here. So, pre-existing atrial fibrillation, and you have to do a transcatheter aortic valve replacement, and procedural atrial fibrillation. So, what are the dangers, AKIs with previous atrial fibrillation? And what about if you have delayed or newer atrial fibrillation after which is known as the pre-procedural, this thing. So how would you define that? Would you give we know the mortality is high if you have a previous atrial fibrillation. So would you give a SAT or a TAP or triple therapy with anticoagulants? What do you prefer, sir?
So I think it's also a very good question. So the thing is, a lot of times aortic stenosis patient becomes symptomatic because they develop atrial fibrillation. So if you see the physiology of aortic stenosis, the LV is hypertrophied, you have an outflow obstruction, the diastolic filling pressures are very high. Atrial fit is very important to maintain a forward cardiac output. If the patient develops the atrial fibrillation, that means the atrial contraction is lost. Now the ventricular filling is totally passive. A lot of time patient develops symptoms because of AF. So you don't want AF in an AS patient, right? That's very important. A lot of times they become symptomatic because they develop atrial fibrillation. So for us, procedurally it's not difficult. We can do it with equal fitness. Post procedure, in this patient needs to be on NOAC, nothing else, just NOACs. No aspirin, no propranolol, just NOACs.
NOACs, not VKA, friends. This is what he's saying.
Because we are going to put a bioprosthetic valve inside and we don't have to give an aspirin also. So during the procedure, obviously patient will be on heparin or low molecular heparin. If we are satisfied, no hematoma, hemostasis is fine, we put the patient on preferably a Pixa band and discharge.
Wonderful, sir. Thank you so much.
Friends, we have Dr. Vivek Kumar here, ex-additional DDHS and actually cardiologist from the hospital, sir. One of the first DMs in cardiology from KBMC. Sir, we had a wonderful session on structural heart diseases, on TAVI, on mitral stenosis, on trach valve. Sir, your comments and your experience.
See, these diseases are now quite prevalent. Earlier, you were not seeing the diseases. As the longevity is increasing, earlier, when the India became independent, the expected survival for a young male, newborn, was only 51 years for a male and 46 years for a female. Today, the survival has gone to 80s. Male and female are expected to live up to 80s. So we are having another 30 years of hiatus, another additional 30 years, in which the diseases which are hitherto not known, not seen, are being seen more and more commonly. Like aortic stenosis. During our MD days, MD DM days, we will hardly see one aortic stenosis in a week. Now we see per OPD at least 3 to 4 aortic stenosis. We are seeing lesser atrial fibrillation. Except for pneumatic. In pneumatic we have a lot of atrial, but now we are having a lot of atrial fibrillation. And Dr. Chauhan, as you asked, now a better therapeutic measures are available, right from DC shock to better antiarrhythmic medicines and electrophysiological assistance to ablate or get off from the atrial fibrillation. So in cardiology, the medicines are changing by leaps and bounds. And as my friend Dr. Tulsi Saab has said, Clip, and AVID, as another 5 years' time, possibly LVSS devices will be more common, they will become more economical, and you will find a more use of them. Like Mitra clips today is very expensive, about 25 to 30 lakh rupees. But possibly with the Indian innovation, it will come around 3 lakh rupees in about 2 years' time to come. So this kind of CME are very, very crucial for those who are practicing structural cardiology and for those who are practicing general medicine to know how can they benefit their patients, sending them to an appropriate center, sending them to an appropriate person who can do a better justification for such patient. Thank you very much. My best wishes again.
Thank you so much. You dwelt upon this in a wonderful way. Talk us how do you tackle nuance in interpretation after transcatheter interventions? Do you give Corderon or probably will subside in about 4 weeks' time? What do you say, sir?
See, ideally, if this is having any hemodynamic impact, then we will not wait or resist electrode conversion.
No, you already
And after that, if the patient is hemodynamically stable, we will put on oral investigation as per requirement and as per dosage requirement, as per body weight, comorbid situations, co-complicated situations, and normally this, if revered, as my dear friend has said, we must not hesitate in using NOACs or warfarin like of situation.
Thank you, sir.
Friends, we had a wonderful CME on structural heart disease by Dr. Vivek. I would request Dr. M L Kalra sir to summarize the key take-home message for all of us.
Dear friends, we had a wonderful talk and interaction. And for Dr. Chauhan, there are two good news. Number one, Dr. Vivek Kumar will give us one more CME because he has mentioned 8 times. I forgot to tell, I forgot to dwell, I forgot to... So there are points. There are pending points. And also Dr. Rakesh Verma, my, what I can say, my hero. He also needs to give us a CME. Sir, we want to know from
I am better here.
the legend, sir. नहीं, आप इधर आओ, इधर आके देखो किसी जगह क्या हो रहा है. Sir, I will moderate your session. And sir, I wish you give us. I have been seeing you for ages. 30 years I have been following you. So you are one of our potential young man. Sir. आपने अल्कोहल सेक्टर एवोल्यूशन कहा था, मुझे लगा कि मैं अल्कोहल पी रहा हूँ, शायद अपने सेक्टर की जो प्रोटेक्शन कर रहा हूँ, ऐसा तो नहीं है कुछ. But what was that? Sir, question answers were so elaborate. We learned so many new things, and I think my friend also learned many new things. So we will do it once more. Dr. Chauhan to take on.
Friends, we had a wonderful session, as you would have understood. We had some good feedbacks from our... Alright, Dr. Sen, just send a case of severe aortic stenosis to Dr. Vivek for TAVI. That will do. Yeah, you are allowed to leave. Or you might just send a case of trach valve to him. Yeah, he also deals with atrial fibrillation. Yeah, and as you would have understood from the ad of Bharat Ek Khoj, Tata Iron Steel and Company, we also make steel. He also makes steel. Wonderful session, sir. Wonderful session. I want to thank from the bottom of my heart the wonderful marketing team of Medtronic, led brilliantly by Mr. Garandi, who was with me at every single step of this event. It's not easy to bring an event, let me tell you. Deven and me worked on an event of Dr. T.S. Clare, and we worked for nearly 28 days together to bring that event to you. So before it brings to fruition and we are able to give it to you on a platter, it takes effort to do it. Therefore, the least I expect of you is to give a big hand to Dr. Vivek. और मैं सिर्फ डॉक्टर विवेक से यही कहूँगा कि you stood out in today's CME. You showcased your skills, and I am sure many of us would have taken the important takeaway message that if there are structural heart diseases, the person to refer to you is Dr. Vivek in many conditions, whether it is trach valve, it is mitral stenosis, it is aortic stenosis, it is TAVI. He is a wonderful, wonderful operator. And as long as he has the kavach of Dr. Viveka, nothing can go wrong with you, let me tell you, my friend. Thank you very much. फिर मिलेंगे कभी, इस बात का वादा कर लो, एक और हंसी मुलाकात का वादा कर लो. Thank you very much.